Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our presenter is going to be Michelle Galvez, a PGY2 EM resident at the University of Kentucky. They'll be presenting on early intensive blood pressure reduction after intracerebral hemorrhage is associated with worse functional outcome, the risk of overshooting blood pressure goals.
To start off, I don't have anything to disclose in terms of conflict of interests. These are just going to be some abbreviations that I'll be using throughout the presentation. And I'll get started. So why does this presentation matter? So intracerebral hemorrhages affects about 2 million people annually worldwide. And of those people that are affected in the United States specifically, about 10% of those are going to be due to hemorrhagic strokes. So we see a lot of strokes worldwide. Here in the US as well, about 8,000 per year are going to be intracerebral hemorrhages. And this is really important because those hemorrhages have a high 30-day mortality with a range of 30 to 50%. And in that category, about only 40% or less actually achieve full functional independence. Diving into some of the pathophysiology. So in terms of spontaneous intracerebral hemorrhages, which is what this is going to be focusing on, they typically result due to a rupture of a small cerebral blood vessel, which can just be due to chronic hypertension or cerebral amyloid angiopathy. Where we see these most commonly in terms of the pathophys, it's going to be deep, so in the basal ganglia, thalamus, the pons or cerebellum, and that is due to more of chronic hypertension, but we can also see them in the lobar portion of the brain, and that's more due to cortical and leptomeningeal arterioles. Now, different trials will use different scoring tools to kind of assess the severity of the patients. I'm going to focus primarily here on the intracerebral hemorrhage score, which is what one of our tools used in the trial I'll be diving into. And this takes in a different amount of variables, such as their GCS score, the age, location, the intracerebral hemorrhage volume, and then if there's any blood present in the ventricles. And this is scored on a scale ranging from 0 to 6. As we approach that 6 score 5, that has a high 30-day mortality, so about 100%, compared to like 0 or 1 with a lower mortality rate. Another tool that is commonly used in these trials observing intracerebral hemorrhages is our modified Rankin scale, which essentially is just going to assess the disability of the patient. This also is a score from 0 to 6, with 0 being no symptoms, and then as we progress through higher numbers, more disability and more assistance needed just for daily activities. Diving into our goals of intracerebral management, the most important one specifically is going to be blood pressure management in terms of this presentation, which I'll discuss here in a little bit. But if patients present and they are on anticoagulation, it is also going to be important to reverse them. We also want to prevent hematoma expansion. If they are a surgical candidate, just having that intervention done as soon as possible, as well as just minimizing second injuries such as ischemia and just optimizing neurological recovery, just so they have a high functioning independence. Now I'll dive deeper into blood pressure management specifically. So these are going to be agents that are primarily used in the emergency department, focusing on IV agents. So we're going to have our calcium channel blockers, our beta blockers, and hydralazine. I am just going to provide a brief overview. So we're going to have our calcium channel blockers, which most commonly we will see nicardipine. Some institutions may also use clobetapine, which are both dihydropyridine calcium channel blockers that inhibit our L-type calcium channels in both vascular smooth muscle and cardiac muscle. The reason these are commonly used is they are going to be titratable, so we can increase or decrease just based to effect in our systolic goals, and they have a rapid onset of action. The next medication class is going to be our beta blockers, which is something we also commonly see in the emergency department, with the most common one being labetalol, but we also have esmolol available if that is preferred. So labetalol is going to be our non-selective beta blocker that's going to inhibit both beta-1 and beta-2 adrenergic and selective for alpha-2 receptors. And then esmolol is more cardioselective, just inhibiting beta-1 adrenergic receptors with little effect on beta-2, except at those higher doses we might see more of those effects on beta-2. Again, both of these can be available as an infusion that can be titratable. However, most commonly, at least here at my institution, we use labetalol pushes, which can be convenient as well. Both are going to have a rapid onset of action, making it favorable for use. Lastly, we have hydralazine, which is another indication to use in intracerebral hemorrhages. And this is going to work by direct vasodilation, and it also helps decrease peripheral vascular resistance. Now, although hydralazine is commonly used, it's a little less favorable just because of the different variability and response individual patients can have. But it is available, and some instances where I am reaching out for that is if they're just a little hypertensive and maybe they're bradycardic, where labetalol push may not be ideal. So reaching out for a hydralazine. And why blood pressure really matters in these patients that are presenting with an intracerebral hemorrhage is blood pressure management helps prevent hematoma expansion, and a lot of different literature has proved that it helps improve neurological worsening and even death. And lowering blood pressure in general is associated with long-term function. However, rapid reductions in blood pressure do pose some potential for adverse effects, such as the risk for cerebral hypoperfusion and even acute kidney injury. Now I'm going to get into some of our landmark trials and a brief background of what has been done prior to this new journal article. Starting off, some of you may be familiar with the INDIRECT 2 trial, which was done in 2013. It was an international multi-center prospective randomized open treatment blinded trial. It was done in about 144 hospitals in 21 different countries, and it was done throughout a period of 4 years from 2008 to 2012, and it was an intention to treat. And this population included adults that had a confirmed intracerebral hemorrhage, whether that was on CT imaging or an MRI, and they had to have presented with a systolic anywhere between 150 to 220 millimeters of mercury. Now, for the interventions, there was 2 different groups. So we had the intensive and the standard systolic goals. So the intensive being less than 140 millimeters of mercury and the standard being less than 180. Overall, for the population baseline characteristics, these patients were about 63 years of age. Their median GCS score was 14, and their median NIHSS score was 10. I know I mentioned that hematoma volume being part of the ICH score early on in the intro, and theirs here was about 11 mLs. For our primary outcome that they were looking at in this trial specifically, for the primary was death or major disability at 90 days. And for the secondary, they were looking at physical function with that modified Rankin scale, all-cause mortality, and just health-related quality of life. What they found specifically in the INDIRECT 2 trial was for death or major disability at 90 days, we saw statistical significance. So that was lower in our intensive group, so 52% compared to 55.6% in the standard group. In terms of our secondary outcome, we also had a statistical significance with it being higher physical function in the intensive group compared to the standard group. In terms of all-cause mortality, there was no major significance between the two groups. And when looking at the health-related quality of life, there was a statistical significance in the intensive group having better outcomes. However, something I do want to point out in this trial was that only 33.4% of the patients in the intensive group actually achieved their goal systolic of less than 140. Another major big trial that you may be familiar with is the ATTACH-2 trial, which was done 3 years later in 2016, which also was an international multi-center randomized 2-group open label trial. This was another large trial done in 173 hospitals in 7 countries with a 5-year period. Again, was adults with a spontaneous intracerebral hemorrhage, and they had to have had a systolic greater than 180 millimeters of mercury, and they had to have required IV antihypertensives. For the interventions, they also had 2 different groups. So we had our intensive systolic group and our standard systolic group, with the intensive being lower than what we saw, or more specific range compared to the INDIRECT 2, so 110 millimeters of mercury to 139, and then our standard group being 140 to 179. Population, we saw mainly 62 years of age was the median. GCS, about 55% had a GCS of 15. The median NIHSS score was 11, and the median hematoma volume was 10.3. Similar primary outcomes with death or major disability at 90 days. And for our secondary endpoints, they were looking at the minimum 2-hour systolic after treatment and hematoma expansion. What this showed at the end was that there was no statistical significance between the intensive group and the standard group, which was different from the results we saw in the INDIRECT 2. When looking at our secondary outcomes for mean minimum systolic 2 hours after treatment, there was the range for the intensive group, so they were within their window. Same with the standard group. When looking at hematoma expansion, which I mentioned earlier in the intro as it being one of our goals, we saw in the intensive group it was 18.9% compared to 24.4%, which was statistically significant. And we also saw more renal adverse effects, which I mentioned can be something that is concerning with rapid reductions of blood pressure, and it was 9% in the intensive group compared to 4% in our standard group, which was statistically significant. Now that I've covered what the literature has said, I want to get into what our guideline recommendations are. So the 2022 AHA-ASA spontaneous intracerebral guidelines have recommendations, and in spontaneous intracerebral hemorrhages that are going to require blood pressure lowering, they essentially state to avoid large peaks in variability in systolic blood pressure to help improve functional outcomes. They also say that a mild to moderate severe intracerebral hemorrhage that have anywhere from a 150 to 220 systolic, that acute lowering to a target range of about 140, with the goal being maintaining that range between 130 to 150 is going to be safe and reasonable. Again, these are class 2 recommendations, so not high recommendations. And they also just mentioned really briefly that in those mild to moderate severe intracerebral hemorrhages, having a systolic greater than 150 or less than 130 may be harmful. Keeping that in mind as we go on to our trial that I'll be going over today, which is early intensive blood pressure reduction after intracerebral hemorrhage is associated with worse functional outcomes the risk of overshooting blood pressure goals. Starting off with the study overview, the purpose of this study was aimed to address the effect of early intensive blood pressure lowering on functional outcomes in patients with intracerebral hemorrhages, specifically spontaneous. What their primary outcomes for this study was for primary looking at the functional status MRS at hospital discharge, and for their secondary outcomes, they had comparing the bolus versus infusion antihypertensive and overshooting blood pressure. They were looking at the 6-hour window or 24-hour window of ED arrival and whether one was associated with higher rates of overshooting their blood pressure goals. For the methods specifically, this is going to be a big portion as this study was very specific in what they did. So it was a retrospective cohort study that was done at Massachusetts General and Brigham and Women's Hospital. And they divided the population into groups of systolic when they arrived to the emergency department. So whether their systolic was less than or equal to 150, whether they were in between 150 to 180, 181 to 210, or greater than 210 millimeters of mercury. What they were looking at was time to goal of the systolic blood pressure, and they measured that, and it had to be either defined as less than 150 within 2 hours of arrival to the emergency department. And what they classified as overshooting was any systolic blood pressure less than or equal to 120 millimeters of mercury after treatment. And they looked at this again within a 6-hour window or 24-hour window after arrival of the emergency department. When looking at what patients they included patients greater than or equal to 18 years of age, and they had to have had a spontaneous intracerebral hemorrhage between January 1st, 2017 through December 31st of 2023. And the way they determined the spontaneous intracerebral hemorrhage was through CT imaging, and they had to have had presented with an initial systolic of greater than 150 millimeters of mercury. For exclusion, for those patients that presented with an unknown or missing unknown class normal, they were excluded from the trial. If the patient was transferred from an outside hospital to their facility, they were also excluded. If they didn't have a blood pressure documented or they didn't have a modified Rankin scale documented, they were also excluded. Or if they had a tumor or they had converted from an acute ischemic stroke into an intracerebral hemorrhagic stroke, then they were also excluded from this trial. When looking at what they did for their interventions and statistical analysis, so there was no specific institutional protocol of what specific antihypertensive agent they had to use. So it was up to the physician to choose whether they did bolus antihypertensives or whether they were starting on infusion. And both were allowed, and it was just based off what was the first antihypertensive agent that was administered. So they could have gotten a bolus and then been started on an infusion. In terms of the data collection, if they were missing an intracerebral hemorrhage score or intracerebral hemorrhage volume and or a GCS, they were essentially manually calculated by the reviewers that were looking at the EMR, and they kind of just estimated, which I'll get into why that might not be ideal. In terms of the analysis, the patient demographic and clinical characteristics was a descriptive statistic. And then for the association between the systolic blood pressure indicators and functional outcome, they used a logistic regression model. Now I'll get into our results and what did this trial show. So in terms of our baseline characteristics, primarily were those that were elderly, so ranging anywhere from 70 to 60 years of age between the two groups. And the two groups were those separated into the systolic goals achieved within less than 2 hours or equal to 2 hours or achieved after 2 hours. And our median ICH score was 2 for our less than 2 hours and 1 for our greater than 2 hours. A lot of these patients were not on anticoagulation, so only about 5.6% in the less than 2 hour group compared to 12.9% in the greater than 2 hour group. And I do want to point out that the MRS at discharge was 5 in the less than 2 hour group compared to 4 in the greater than 2 hour group. And a lot of these patients were actually discharged to another health facility, and which is something I do want to highlight as well. So about 22% in the less than 2 hour group and 50.5 in the greater than 2 hour group. And that is going to be crucial in, were these patients so sick that they had to continue on into another health facility in order to have improved functional outcomes. So just keep that in mind as we go through the rest of the results. For our primary outcome, I had mentioned that was our modified Rankin scale. So in the box at the top, we can see that the patients that achieved a goal blood pressure less than or equal to 2 hours had a higher percentage of poor outcomes. So the poor outcomes being an MRS score of greater than 3. So we can see that here highlighted in the different blues, compared to the bottom box when goal blood pressure was achieved at greater than 2 hours. We saw higher percentages of that good outcome, and so meaning an MRS score of 0, 1, or even 2. When looking at the takeaways from this, is that patients with an ICH and a arrival systolic greater than 150, they had worse functional outcomes, so an MRS score of 4 to 6, when the blood pressure was reduced within or less than 2 hours of admission, compared to those that had it achieved greater than 2 hours. Looking at our secondary outcomes, I know this table can be a lot, but I've highlighted here a few boxes that I want to go ahead and focus on. So for the group that presented initially with a systolic between 151 to 180, at baseline, they had a higher percentage of it having an MRS score of 4 to 6, that being 78% of those patients had a higher mortality rate just when they arrived. And that is also seen in the group that had a systolic blood pressure greater than 210. When looking at the time to goal, again, whether that blood pressure was achieved greater than 2 hours or less than or equal to 2 hours, we saw higher percentage of those patients had an MRS score of 4 to 6, indicating higher mortality. So in that group of less than 2 hours, it was 86.1% of those patients had that higher mortality. When looking at whether their blood pressure was overshot within 6 hours, we can see in the within the 6 hour period, we saw about 90.6% had it overshot, and only about 82% had it overshot within a 24-hour period. However, when looking at the MRS score, there was no major difference between the no and yes group in the 24-hour period. Some key takeaways are going to be that most patients presenting with an ICH had a blood pressure between 151 to 180, or that higher range of 181 to 210. Higher MRS scores were associated with a decreased blood pressure within or before 2 hours after admission, and overshooting the blood pressure below 120 at 6 hours was associated with higher MRS scores. But again, there was really no difference when looking at it within the 24-hour period. They also looked at poor outcomes by the subgroup analysis. Again, this is a lot to look at, but I want to focus on those patients that had a systolic greater than 210, as those patients had a higher percentage of poor outcomes So about 91.1% when achieved in less than or equal to 2 hours. There's no major difference between the last known well in terms of hours. Just to summarize our outcomes, higher arrival systolic blood pressure is associated with worse outcomes in patients with intracerebral hemorrhage. Early blood pressure control, so less than 150 within 2 hours of the ED arrival, was associated with worse outcomes. And those patients who achieved early blood pressure reduction and remained within target did not have better outcomes than those that didn't achieve the early blood pressure control. The author's conclusion was that rapid reduction of blood pressure in intracerebral hemorrhage resulted in worse functional outcomes, and the recommendation that blood pressure reduction earlier on, so that range of 130 to 150 within 1 to 2 hours, leads to better outcome may not be as accurate for all patients presenting with an intracerebral hemorrhage, and the findings highlight the need for more patient-specific approach to blood pressure management. For my critique and personal opinions, there's a lot of strengths to the study. So it is a clinical relevant question of what we should be doing in terms of blood pressure management in these patients presenting with an intracerebral hemorrhage. For it being an observational study, they had a decent sample size. They did have some adjustments for key confounders, and they had an early MRS evaluation, and it was appropriate for the functional outcomes of using MRS, as that's what a lot of different trials have shown. And 71% of the patients actually were able to achieve the goal blood pressure within the 2 hours. However, there was a lot of limitations to this study that I specifically found. So, of course, it being a retrospective observational design, the MRS at discharge as a primary outcome might not be as meaningful or impactful as maybe death or MRS at 90 days. There was a lack of that protocol of which I mentioned for use of antihypertensive, and they actually didn't disclose any of the data for the antihypertensives of what was used. They just said there was no difference in the overshooting between the two. And it also wasn't stratified by the severity, or they didn't disclose the location of the intracerebral hemorrhage. Again, as I mentioned in the design, they used arbitrary intracerebral hemorrhage scores and GCS. So if it wasn't documented, just using it based off the physical exam. And overall, something that I think is crucial is they only used a single blood pressure measurement without subsequent readings. So those patients could be out of that range and we wouldn't know it, and it wasn't disclosed. And a lot of those patients, as I mentioned earlier, were discharged to other healthcare facilities. And the biggest one, especially for institutions like the University of Kentucky, where I'm at, they excluded over 1,700 patients due to them being a transfer from an outside hospital. A lot of times in my practice, what I see is patients coming to higher level of care in these bleeds. So overall, just to summarize, my own opinion and clinical application was this trial had many limitations, which might make it less applicable to our large academic centers. And there was a lot of key factors that were missing from the study. While this study specifically is not going to change my clinical practice, it does raise the question in my own head of blood pressure management in those patients that are presenting with initial systolic blood pressure of greater than 210 and how I might manage or approach those patients. I do think that future studies should focus on patient-specific driven blood pressure goals. And I think it would be more beneficial to see the adverse effects with different medication administrations, whether it's a bolus or infusion. These are my references. This is my Journal Club mentor. Thank you to Dr. Bowe. And I'll open the floor to any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of each journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.